Define healthcare associated infections. Classify. Definition of healthcare associated infection HCAIs. Healthcare associated infection, also known as nosocomial or hospital acquired infections, are infections acquired by a patient in a hospital or healthcare facility. To be classified as an HCAI, healthcare associated infection, infection must meet the following criteria. The patient must have been admitted for a reason other than that specific infection. The infection must not have been overtly present or in the incubation period at the time of admission. Symptoms typically appear at least 48 hours after admission. The definition also extends to infections that are acquired during hospital stay but only become evident after the patient is discharged, as well as occupational infections acquired by the medical staff working at the facility. Classification of healthcare associated infections. Infections of HCIs can be classified into two primary ways: by the source of the infecting microorganism and by the clinical site of infection. First classification based on the source of infection. In that endogenous infection, self-infection, we can say endogenous cell infection. A high proportion of clinical hospital infections are endogenous. These occur when the infecting organism is derived from the patient's own normal microbial flora, such as from the skin, gastrointestinal tract, or upper respiratory tract. These commensal organisms can invade the patient's tissues spontaneously when host defenses are lowered, or they may be introduced into deeper tissues during surgical operation, instrumental manipulation, and nursing procedures. Endogenous infection. A high proportion of clinical hospital infections are endogenous. These occur when the infecting organism is derived from the patient's own normal microbial flora, such as from the skin, gastrointestinal tract, and upper respiratory tract. These commensal organisms can invade the patient tissue spontaneously when host defenses are lowered, or they may be introduced into the deeper tissues during surgical operation, instrumental manipulation, and nursing procedures. Exogenous infections. Exogenous infections, which include the exogenous infections, which include these infections are acquired from the source of outside the patient's own body, the source of outside the patient own body. These are further divided into cross infection, exogenous infection. Infections are from sources outside the patient's own body. Sources outside the patient's own body. They are further divided into cross infections spread directly from another person in the hospital, such as other infected patient, asymptomatic carriers, or hospital's personnel. Environmental infections spread via contaminated inanimate objects and building services within the hospital. This include medical equipment like catheters, endoscopes, bedding, floors, air, water, and food. Environmental infection. Classification based on the clinical site, most common type. Classification based on the clinical site, most common types. In any hospital, HCA is predominantly present in four main forms. So other localized infection can also occur. Urinary tract infection, the first one, urinary tract infection. This is the most common type that of HCA, accounting approximately 33% of the cases. Most of these are associated with urethral catheterization. Common causative pathogen include Escherichia coli, Klebsiella, Proteus, Pseudomonas, Serratia, Enterococci, and the fungus Candida albicans. Urinary tract infection, the most common type of SCA, accounting for approximately 33% of the cases. Most of these are associated with urethral catheterization. Common causative pathogen include Escherichia coli, Klebsiella, Proteus, Pseudomonas, Serrata, Enterococci, and the fungus Candida albicans. Respiratory infection, nosocomial pneumonia, accounting 15 to 20% of hospital infections. These are frequently occur In intensive care units, particularly as ventilator associated pneumonia, VAP, they often arise from aspiration in unconscious patient or through pulmonary instrumentation. Major pathogen include Staphylococcus aureus, Pseudomonas aeruginosa, Acinetobacter, Klebsiella, Enterobacter. Respiratory infection, nosocomial pneumonia, accounting for 15 to 20% of hospital infection. These frequently occur in intensive care unit, particularly as ventilator associated pneumonia. They often arise from aspiration in unconscious patients or through pulmonary instrumentation. Major pathogens include Staphylococcus aureus, Pseudomonas aeruginosa, Acinetobacter, and Klebsiella and Enterobacter. Surgical site wound infection, accounting for about 15% of SCIs. These infections typically present within a week of surgery. Staphylococcus aureus is the predominant pathogen here. This category also include infections of non-surgical wounds like bed sore, umbilical stumps, and burn wounds, whereas that P. aeruginosa is notoriously the most common and serious disease. Bloodstream infections, bacteremia, and septicemia. Accounting for roughly 13% of HAIs, these are often the direct consequence of infected intravenous cannulae, catheters, or can be secondary to infections at other sites. Central vascular catheters account for 80 to 90% of these infections. The most common pathogen is isolated from vascular device associated bacteremia and coagulase negative staphylococci like ZS epidermidis through gram negative bacilli are also frequent culprits. Gastrointestinal infection. Hospital can also be sites for food poisoning and antibiotic associated diarrhea. Common agents include Salmonella, Shigella soni, Clostridium difficile, the latter of which causes severe colitis when normal bowel flora is depleted by antibiotic therapy. Blood spill management. Managing a blood or infectious spill requires strict adherence to safety protocol to prevent the transmission of bloodborne pathogen. Based on the sources, here is the detailed step-by-step procedure for infection spill management. First, secure the area. Immediately block off the area of the spill to prevent anyone from walking through until the infection process is completely finished. Personally protective equipment (PPE). Before handling the spill, put an appropriate PPE, including non-sterile disposable gloves, a gown, and a mask or a face shield if splashing is anticipated. Manage broken glass shrubs if applicable. Never pick up a broken glass with your hands. Use a pan and a brush to be carefully sweep up any broken glass and dispose of it immediately in a puncture-proof sharps container. Absorb the spill. The place paper towels directly over the spilled blood or body fluid to absorb the bulk of the liquid. Apply disinfectant. Pour a sodium hypochlorite bleach solution carefully over the paper towels and all contaminated areas. Typically, a 1:10 or 1:100 dilution of sodium hypochlorite used for this process. Some guidelines specifically recommend a 10% of sodium hypochlorite solution for spillage cleaning. The active component of this process. Some guidelines specifically recommend a 10% sodium hypochlorite solution for spillage cleaning. The active component in this process is hypochlorous acid, typically 5 to 6% in standard bleach formulations. Allow contact time. Leave the bleach solution on the spill for 20 to 30 minutes to ensure all pathogens are effectively inactivated. Clean up the spill. After the contact time has elapsed, wipe up the bleach solution along with the soaked paper towels. Safe disposal. Carefully remove your gloves and place them along with all the soiled paper towels and cleanup material into a designated plastic bag and tie it securely for proper disposal. Final cleaning. Once the infectious material and bleach are removed, clean the surface area as you normally would using standard detergent and water. Reporting. Finally, Inform the hospital's infection control authority about the spill and subsequent cleanup so it can be properly documented. Standard precautions, also known as universal precautions, are a fundamental set of infection control practices designed to prevent the transmission of the diseases acquired by contact with blood, body fluid, non intact skin, and mucous membranes. These precautions must be applied to all patients at all times in all healthcare situations, regardless of their known or suspected infectious state. Standard precautions like hand hygiene. Hand hygiene is considered the single most important measure for preventing the transmission of healthcare associated infection between the patients and healthcare worker. WHO's 5 moments of hand washing. Hand hygiene must be performed before touching a patient, before an aseptic procedure, after body fluid exposure risk, after touching the patient, after touching the patient's surroundings. Alcohol based hand rub preferred method uses 70 to 80% alcohol plus 2.2 to 4% chlorohexidine. It is more effective, easily available, and less drying to the skin and does not require water or a sink. The duration of contact should be 20 to 30 seconds until it evaporates. Hand washing with soap and water. This is mandatory when hands are visibly soiled after using the toilet, before, after eating, and when handling the patient with diarrhea or incontinence. The duration of hand washing should be 40 to 60 seconds. Personal protective equipment. PPE must be used based on the anticipated risk of exposure and must be removed and disposed of properly after use. Followed immediately by hand hygiene. PPE should never be shaved or come into contact with contaminated surfaces. Gloves indicated for contact with blood, body fluid, mucous membrane, and non intact skin. They are for single use only. Sterile gloves are used for invasive procedure, while non-sterile gloves are used for routine care. Facial protection, mask, goggles, face shield indicated when sprays or splashes of body fluid are anticipated to protect the mucous membrane of the eyes, nose, and mouth. Gowns and aprons used to provide protection for clothing and skin when splashes or sprays of body fluid are expected. Respiratory hygiene and cough etiquette applicable to patient, healthcare workers, and hospital visitors to contain respiratory secretions. The nose and mouth should be covered with a tissue while coughing, sneezing, or blowing the nose, followed by prompt disposal of the tissue in a dustbin. Constantly coughing patients should be provided with a surgical mask and kept at a spatial separation of at least 3 feet from others. Safe injection practices and sharps handling. Sharps are highly hazardous because they can puncture the skin and grant direct access to pathogen. Injections. Use sterilized disposable needles and syringes. Single dose vials are preferred. Clean rubber septums on medication vials with alcohol before piercing and strictly adhere to the asepting techniques. Sharps handling. Avoid unnecessary use of sharps and never pass them hand to hand. Needles must never be recapped, bent, or mutilated by hand. Sharps should never be left on trolleys or bedside tables and must be disposed of immediately in puncture proof container. Decontamination of patient linen. Patient linen must be changed daily. If visibly soiled by blood or body fluid, it must be changed immediately with minimal agitation. Linen from patients infected with HIV, hepatitis B or C, MRCA must be decontaminated by autoclaving or soaking in 1% sodium hypochlorite or 7% Lysol before being sent to the laundry. Environmental cleaning and spillage management. Routine cleaning, regular cleaning, and disinfection of the environmental surfaces such as bed rail, bedside table, floors, handle, sinks, and toilets must be maintained. Spill management. Any spillage of blood or body fluid should be cleaned and decontaminated using 10% sodium hypochlorite solution. Universal precautions in the laboratory. Laboratory and healthcare workers handling clinical specimen must take specific precautions to avoid bloodborne pathogens like hepatitis B and HIV. Assume all specimens are potentially infectious, and place them in a leak-proof, impervious bags for transport. Never pipette by mouth. Always use mechanical pipetting devices. Perform procedures prone to aerosolization or spattering inside biological safety hood. Decontaminate laboratory work surfaces with appropriate disinfectants after work is completed or after any spill. Remove all protective clothing and wash hands thoroughly before leaving the laboratory.